clinical studies of patients undergoing new treatments and therapies and publishing articles in peer-reviewed medical journals. She has co-authored over 90 peer-reviewed articles over the past 15 years. She is part of Dr. Nalini's team at NIMHANS. Dr. Priya Thomas is an additional professor at NIMHANS, Bengaluru. She is interested in how human beings respond and cope with chronic illness in life. Dr. Priya is engaged in developing and rendering psychosocial interventions in neurological disorders. She has special interest and expertise in qualitative research methodology, long-term and palliative care for chronic neuropsychiatric conditions. Her paper published in August 2014 on the psychosocial challenges in family caregiving with children suffering from
Ma'am, your voice is lost. Sharda ma'am. Hello.
I'm sorry, there was my line got disconnected. Can I continue?
Yes, please.
Yeah, a warm welcome to both the doctors who have taken the time to address our concerns and share their knowledge and expertise with us. We also extend a warm welcome to Dr. Veena Vedartham, neuromuscular specialist from Manipal Hospital, and Dr. Gauri Raghunath, MD Pathology, who have shown interest in treating and helping people affected with muscular dystrophy. I would just like to mention a few things. We request all viewers to kindly mute their audio and turn off their videos to ensure a smooth transmission, please. And once the doctors have presented and the registered questions have been taken up, people can raise their hands and we will try to address all their questions. Thank you. Doctor, over to you, Dr. SEENA.
Thank you, ma'am. So how shall I go about? Thank you for inviting us for this webinar. And also, I'm very happy to interact with you all. So how shall we go about this program? Shall we just start telling you about the Duchenne or just start answering your questions one by one?
Ma'am, it would be better if you can just give us a brief background about how we need to go about it, what we need to do, and then probably you can take up our questions.
Okay, fine.
Can I kindly ask you to keep the video on, Ms.
My video is actually on, but I don't know. You are not able to see me, is it?
No, we are not able to see you.
Maybe I'll try logging in from another computer. Maybe I don't know whether my desktop here has a problem. Then just give me a minute. In that meantime, maybe Priya madam can just start interacting with you. Just give me a minute. I'll log in from another one.
Okay. Thank you, ma'am.
So can you hear me and can you see me?
Yes, ma'am. Thank you so much.
Right. So while SEENA is processing her connection, I just want to add my thanks to the organization and also to all of you. It's our pleasure to be here, and in whatever way possible, if we are able to address some of the concerns that have been raised, that is what we hope to do. In order to achieve the purpose, I think it will be good if SEENA presents first with regard to the neurological management, and then we will move on to how we manage the psychological and social issues. Is that okay, Ashwini?
Yes, ma'am. It's okay. We can wait for a few minutes.
I think it is better. Otherwise, it will be a little bit jumping the gun kind of thing. So.
Yes, ma'am. We can wait, ma'am. Thank you.
Am I visible now, ma'am?
No, ma'am.
There is
Uh,
some problem with your video, SEENA.
okay, because
Yes.
Yes.
no, it
Now
is-
you are. Now you
now you-
can be seen. Yes.
I think it was allowing me to join only from one. So I virtually
This is now fine. We can see
fine.
you.
Okay, just 1 minute. I'll just try to share one of the PPTs also. It's not a very systematic presentation, but just so that you can have an overview about that. Is my slide seen, ma'am?
No,
No.
ma'am.
No. Okay. One second. Now is it seen?
Yeah.
Yeah.
Yes, it can be seen.
Okay. Yeah. Okay. So, say very thank you all once again. So, Duchenne muscular dystrophy, so as you all know, it is one of the most common muscular dystrophies, which affects mainly males, and it has a higher prevalence and incidence of about 1 in 3,500 male live birth.
SEENA,
So
sorry.
actually, I have.
You can put on a slideshow.
Oh, it's not come in slideshow.
It's not coming
One
in
second.
slideshow.
Now is it coming?
Yes.
So as of now, actually, the slides are mostly prepared based on your questions. Actually, I just wanted to show the slides based on what questions you asked. So it's not a very orderly presentation. So basically, it is due to a mutation in a protein which is known as dystrophin. So you have raised questions about Duchenne, about the various presentations, about career status, etc. So it's an X-linked disorder, means basically the females have 2 X chromosomes. So the mutation in the child can be sporadic or it can be transmitted from the mother can be a carrier and the child can get the disease. So there are different presentations. The most severe presentation of a dystrophinopathy is called Duchenne muscular dystrophy, whereas the milder form is the Becker. So there are some intermediate phenotypes called outliers who can present either have manifestations between the two, and sometimes they can present only with dilated cardiomyopathies. So basically, this I may tell you later. There are basically 79 parts of the dystrophin gene, and this is how the various drug trials work. So I'm not going into that right now. So I can tell you about the dystrophin isoforms because somebody had raised a question about what are these dystrophin isoforms? How is it that some children have a high incidence of autistic spectrum or attention deficit hyperactivity disorders, or other problems like OCDs or anxiety disorders. So various studies have shown that. So this dystrophinopathy or Duchenne muscular dystrophy is not something which may remain restricted to the muscle. 30% children can have cognitive impairment. 40% can have reading disabilities. So there are various associated things like attention deficit hyperactivity disorders, autistic spectrum disorders, anxiety. 6% can have epilepsy. So various neuropsychiatric manifestations can be there. So it is exactly not known whether these cognitive problems remain the same or whether they progress with aging, just as how the muscle disease progresses. So mainly these children have problem of progressive proximal muscle weakness. So initially parents might notice that they have difficulty in getting up from the floor, difficulty in climbing stairs, difficulty in running, they had delayed motor milestones, they tend to fall down frequently.
And these symptoms may be evident by the age of 4 to 5 years, and gradually the weakness progresses, and then they may lose ambulation and become wheelchair bound. So does these problems of cognition also progress with aging, or whether it stabilizes? Well, some studies have even also shown some improvement also with time. So this is because this protein which is produced is not just present in the muscle. So there are various so-called isoforms which are present. So one is the full-length muscle form which is present. There are some forms which are present. What we have written in the cortical form means the cerebral cortex in the brain. There are some which are present in some of the cells which control the balance. There are isoforms which can be present in the peripheral nerve, in the retina, etc. So this manifestation. So why some children will have little difficulties in scholastic performance? They have attention deficit hyperactivity, while some do not have. So it depends upon, studies have shown that it depends upon which isoform. So in people in whom it is the particular genetic defect is causing only the muscle isoform to be affected, or only the full length form to be affected, the cognitive problems are lesser. Whereas some of these so-called shorter form, the DP140 and all which is missing, they have more problems with cognition. And when the brain MRI is taken also, it has been found that there are changes in these children with Duchenne muscular dystrophy. So it depends upon, and also the genes which are controlling for this dystrophin, they are also co-localizing with some of these which are for autistic spectrum and other intellectual disabilities. That may also explain why these abnormalities can occur. And the studies are yet to show fully some of these changes, but it mainly depends upon the fact that some of these isoforms are present in the fetus itself, while some are expressed later. So it depends upon whether the genetic defect is affecting that isoform which is present in the fetus, so the time in which it is affected, as well as which isoform the mutation is affecting the production of, which all are important in knowing about the cognitive impairment. So these are regarding whatever I think clinical features in which you had doubt. I think I will then go on to regarding the steroid therapy for these people. So steroids. So steroids, you all had doubt. Parents are very hesitant about starting steroids. When should they be started? What all we should be careful. So steroids are the main cornerstone of therapy in the medical management of Duchenne muscular dystrophy. So we use mainly two forms. One is prednisolone, one is deflazacort. So how much to give, that is weight based. So we calculate at either 0.75 milligrams per kg for prednisolone or 0.9 milligram per kg of deflazacort. So you might ask why you should give this. It is important to give steroids because studies have shown that these steroids will improve the motor functions. It will prolong the ambulatory functions. It will help in retaining the motor functions, prolong survival. And it is not just in terms of the hand or the leg strength or power. It also helps in protecting against the scoliosis, the so-called bent spine developing. And also the other pulmonary complication, the respiratory muscle weakness, the cardiac problems, etc. So the next doubt may be which one is better? Should I use deflazacort? Should I use prednisolone? So both are said to be equally effective. So studies have been found that one is superior to the other. So, and it has been, as I mentioned before, that deflazacort or use of steroids can increase survival by 10 to 15 years of treatment. So it also has been found to prolong ambulation by a few years. So which one has more side effect? If both are equally effective, is there any difference in their side effect profile? So most of the side effects of steroids, as you all might be knowing, are weight gain, osteoporosis, other chances of infections. So in all those, there has not been much difference in the literature. But generally, it has been found that prednisolone causes more weight gain, especially in the first 12 months of treatment. While for deflazacort, there is a slightly increased risk of cataract. But if to tell in our personal experience, so though the problems of infections, cataract, etc. are noted, chances of blood sugar going up, blood pressure going up, in children, we don't usually find most of these problems. We have a huge cohort of Duchenne muscular dystrophy children who are regularly visiting our neuromuscular clinic. We haven't encountered any major infection on our children who have been on steroids for many, many years. And for that matter, cataract or other complications are also very less. And many of them, as regarding the benefit, as I mentioned, They are all ambulant for long years. So 16, 17, 18 years also, some are able to maintain their ambulatory ability. And also regarding the blood sugar elevation also, we haven't encountered anybody having such problems. And then what are the other things to take care? So it is, in both are equally effective. So the child can be on any one of these. So when should the steroid be started? So usually most of the children come to us for a diagnosis, usually by 5 to 6 years of age. So we usually start the steroids by around 5 years of age. But in some countries, the recommendations vary. I think in Australian guidelines, they recommend after 2 years it can be started. But generally, we start after around 4 to 5 years of age. So it was to avoid the chances of growth stunting and other problems. And thereafter, we have to continue it regularly. So when should the steroid be stopped? The steroid can be continued even when they have lost ambulation, because as I mentioned, it is not just for the legs, not just for walking. It helps in retaining the hand functions, the upper limb functions. So it helps in maintaining. So you have to continue the steroids, and also for scoliosis, cardiac problems, etc. But we reduce the dosage of steroids if somebody has lost ambulation. We come down to say 0.5 mg per kg or less, and then we continue it at that dose. So what are the other precautions which we have to take? So generally, we tell some of our children have some weight gain while some do not have despite being on steroids. So to tackle obesity and related things, you can maintain a good healthy diet and avoid a very high calorie. For example, the high calorie foods, excessive carbohydrates, all these can be avoided if the child is putting on too much weight. And also there are even intermittent steroid regimens which are recommended, but we generally follow the regular steroid regimen. And so that is one is regarding the dietary aspects. The other things, there are chances of infections which are told, but in our experience, generally the infections are less. But routine vaccination is recommended for all the children. So they should receive vaccination as per the National Immunization Program. So along with that, it is also recommended to give them the influenza vaccine as well as the pneumococcal vaccine, so that these children do not get any recurrent infections. So annual influenza vaccine can be given. So generally, the live vaccines are not preferable in these children who have a sort of said to be low level of immunity. So therefore, the inactivated preparations are preferred. And also the pneumococcal vaccine can be given prior to initiation of the corticosteroid therapy. And theoretically, they say the protection or the afforded by these vaccines may be poor in these children. So, but generally with the steroid equivalent which they are giving, so we don't find much of problems. And live vaccines can cause severe disease. So we should avoid that. So you might also ask, can I give vaccine if there are if my child is having any fever or other infections? So if it is a mild infection, it doesn't matter. You of course can consult with your pediatrician and go ahead with the vaccinations. So that is another thing regarding the vaccination. So of course, the neurologist or the pediatrician who is following up the child will also put the child on medicines to prevent any acidity or the related problems. And also, they will also be given medicines to take care of the bone health. So bone health is another aspect, I think, which you wanted to know. So regarding the bone health, so we give them good doses of calcium supplements, and also vitamin D levels generally are found to be low. So again, if you see the worldwide literature, the vitamin D levels in various studies, it differs, and also it depends upon what kind of testing is also done, and therefore the cutoff levels vary in different studies. And some studies have found that we have to give a high dose of vitamin D actually in these children so that their vitamin D levels are sufficient. Especially, they can undergo a bone densitometry scan and also the level of vitamin D3. And then accordingly, we can give, maybe they require a high doses like 1000 units per day so that the vitamin D deficiency can be tackled. And if there is so much of osteoporosis, use of other bisphosphonates like zoledronic acid can also be tried. So for all this, you can consult the neurologist or the pediatrician or an endocrinologist who can do this annual bone densitometry scans and give appropriate advices. So that was another question which was asked. So who are the other specialists whom you should consult? So the management of Duchenne muscular dystrophy is not just limited. The team doesn't just, it's a multidisciplinary team. So it is not only by the neurologist. So it's a team which is consisting of physiotherapists, occupational therapists, the swallowing assessment if needed, and also by the psychiatric social workers, the genetic counseling by the geneticists, pulmonologists, cardiologists at different stages of the disease, and endocrinologists, or management of the nutritional status. You might require the help of a dietitian and a nutrition specialist. So there are multiple specialities which are involved in the care, and orthopedician. So there are multiple specialists who are involved. So, but you don't have to routine. So it is a multidisciplinary team, but some of the specialities which I mentioned may depend upon the stage of the disease or the abnormalities which are present. So other than this, other than regarding the steroid, physiotherapy, I think was a question. So physiotherapy, when you should start. So physiotherapy is an important aspect of the management. It can be started in the early stages itself. So because these children have very high chances of developing contractures, the range of motion of the joints have to be maintained. So regularly they can undergo some home-based exercise. So in our multidisciplinary neuromuscular clinic also, we have regularly our physiotherapists, occupational therapists who will teach home-based exercises. And depending upon each patient, there are various stretching exercises, home-based exercises. So if we compare studies which have shown children who are on regular physiotherapy versus no interventions, the exercises have shown definite improvement in the muscle strength. So there are again various type of exercises, stretching, active and passive for the joints. So the exercises can be done daily, morning and evening for 5 to 10 minutes. And too much of rigorous exercises can be avoided. And also walking, swimming, cycling, all these can be allowed for the children. Isometric exercises are mostly useful for these children. So that is regarding the aspect of physiotherapy. And I think you had asked about what about the stress dose of steroids. So this is something which is recommended. See, supposing the child is having an emergency surgery for some reason, some fractures, some stressful situations. So because they have been on chronic steroid usage, so there may be a suppression of the hypothalamic pituitary adrenal axis, so that when the body is under stress, the adequate levels of stress hormone are attained. So there are various recommendations. I don't think you have to know about how to convert and all, because this has to be managed by a neurologist and the team. So how much of they will give injectables at the time of the stress if needed, that is hydrocortisone injections can be given. So there are various, depending upon how severe, what kind of stress it is, the various corticosteroid regimens are there. And also somebody asked about what about a change in the steroid brand. Okay, so you can actually convert the prednisolone or deflazacort, as I told, both are equally effective. If you need to convert from one to another, there are equivalent doses which are known for both. So we calculate accordingly and we can convert the same. So steroids, as I mentioned, can be continued. Another doubt was, so if the child is on any other medication, so can it be given with steroid, or whether steroid should be stopped? So there is no need of stopping the steroids. You can continue the steroids. So I think there was also a question of whether steroids have to be stopped at any time. So most of the time not needed unless there is some particular complication, like child is having some pneumonia or some other things which are causing problems. So otherwise, usually there is no requirement for stopping the steroids. So there was also a question about the sleep pattern, sleep problems. So as autism and other disorders are common in these children, if they have sleep problems, can melatonin be given or other drugs be given? Of course, the sleep problems in Duchenne muscular dystrophy children may be due to multiple factors. So one is per se they have weakness, so they have difficulty turning in bed, so they might need assistance. So other problem is sometimes they can have obstructive sleep apnea because their muscles are weak. Another thing is respiratory failure. So generally, so these are all later various classifications. So the disease per se is divided into an ambulatory stage. So when they are in the early stages of the disease, say up to 10 years of age, the late ambulatory from 8 to 18 years. So maybe the early non-ambulatory stage when they are bedbound, and the late non-ambulatory stage. So as you can see that the bending of the spine also keeps increasing. So accordingly, initially when they are in the early stages, so once yearly pulmonary function tests are sufficient. So later, as maybe twice yearly pulmonary function test has to be done. So if there are sleep abnormalities, we may need sleep studies, so-called polysomnography and others. And as I mentioned in the early stages itself, we give immunization with influenza pneumococcal vaccine to prevent these complications. And again, in the late stages, they might, once they have lost ambulation, they might require more frequent monitoring. Depending upon the problems, they might need devices. Like, for example, they might need assisted coughing. There are various cough assist devices. They may need non-invasive ventilation at night. So there are various interventions which can be tried if the sleep problems are related to the respiratory failure or the breathing problems. Other thing is insomnia, as you told, because they have various medications may be there, stressors may be there. The children may be more addicted to video games or other poor sleep hygiene can be there. They might be having pain. So various problems might be there which contribute to the sleeplessness or insomnia. So good sleep practices can be tried. Melatonin can be tried. It is a safe medicine. So melatonin has been again tried in Duchenne muscular dystrophy for two things. We won't find any studies regarding management of insomnia per se, but generally it is safe. So it depends upon the weight of the child, how much you can give. It can be safely given for weeks or months together without problems. And also it has been also been tried because of its anti-inflammatory effect per se in the Duchenne muscular dystrophy. There are one or two studies also which show regarding the same. So the other questions were like, what if the child requires an anesthesia? So regional or local anesthesias are safe in these children. You can go for spinal, epidural, etc. But only thing is, if there are any bent spine and other things, sometimes ultrasound guidance may be needed. And generally, the anesthetist with expertise in these kind of situations will be knowing which kind of anesthetic to use. So actually, we should avoid using the depolarizing neuromuscular agents. There is something called succinylcholine and all, which are some of the commonly used anesthetic agents, but these are not good in children with Duchenne muscular dystrophy or other neuromuscular disorders. We can use some of the non-depolarizing neuromuscular ones. There are drugs called rocuronium, etc., which are useful. And after a surgery, the main thing is early mobilization is very important, because with periods of prolonged immobilization, the motor abilities and the skills of the children can come down. Their walking speed can come down. So if there is any difficulty in fractures or other things, early surgical interventions may help, and also early mobilization must be tried. So these are regarding the fall and fractures. So early surgery is very important. Prevention is also very important. So because with studies have shown that Duchenne muscular dystrophy children, there is a 25% of the children do develop fractures at some stage. And but with recurrent fracture, which is happening with each fracture that happens, their walking speed or other abilities like getting up from the floor comes down. So there can be safe ways for mobilization. So that is also very important. I think I've skipped a few slides in the beginning. Maybe I'll just cover up those. So I think I won't tell about the exon skipping unless you have some doubt about that. Carrier testing was another thing which was asked. So carrier testing is advocated for all the mothers of Duchenne muscular dystrophy children. And if a carrier status is positive and a subsequent pregnancy is being planned, then, and about the genetic testing also, nowadays, the standard of care is MLPA. Previous times it was PCR. Now MLPA testing is done. And because majority of the Duchenne cases are due to so-called deletion or duplication, which will be picked up in that particular test. So if it is negative, then we go to the next level testing, which is known as next generation sequencing. So in which we pick up the mutations. So if we once we diagnose the disease in the child, the mothers also undergo the carrier testing. If their carrier testing is positive, then there is a 50% chance that in the subsequent pregnancy also, the male child can be affected. So what we usually follow is we advise sex determination in the subsequent pregnancy with the prescription or the advice of your treating neurologist. So the sex determination can be done in the early stages of the pregnancy itself. And if it is a female baby, the pregnancy can be continued same way. If it is a male baby, they require some amniocentesis and other tests in the child to see whether the child is affected. So this should be the standard of care. About whether the carrier mothers can have problems. So they can have sometimes no symptoms at all. Sometimes they can have milder symptoms like muscle pains, muscle cramps. They can have mild limb weakness, like mild difficulty in getting up from the floor, mild difficulty in climbing steps. So various studies report almost like 20% can have some muscle symptoms, and some of them can have dilated cardiomyopathy that again 7 to 8% can have. So the symptoms might be like exertional breathlessness, some feeling of breathlessness or palpitations when they are exerting. Rarely, like in the form of a bent spine, it can present. So if these mothers, what all testing they should undergo? So usually CK is done first, genetic testing for confirming the carrier status, and then they can undergo yearly cardiac evaluations with echo, ECG, etc., which might find changes. But echo, even in the case of Duchenne children or with the case of carriers, so we might find more profound changes only, like if there is a cardiomyopathy or if the pumping comes down, only then we might find changes. So if to detect it early, cardiac MRI is something which will be useful. So if there are abnormalities, whether it be in the case of the carrier or the Duchenne child, it can be managed by a cardiologist. So one aspect which I didn't tell regarding the Duchenne muscular dystrophy child is also usually our standard of practice along with the steroids, other calcium D3 supplements. We also start a medicine which belongs to the group of angiotensin receptor and angiotensin and converting enzyme inhibitor, that is ramipril. We start at a low dose after 10 years of age because the echo and things may not show changes. So we used to do cardiac MRI sometimes in Jayadeva Hospital, so which have shown changes even when the echo is normal. So we can, but we are not able to do it for everybody. So it's our practice that after 10 years of age, we start a low dose of cardioprotective drugs. So somebody also raised a problem of fat embolism. So this is nil in our personal experience, to be frank. But the literature states that as these children have risk of fat embolism, fractures, so are risk of fat embolism there. So this is something which can present with some consciousness disturbance. They can have skin rash, they can have breathing problems. But if you see the worldwide literature, there are only few cases which have been reported. So again, if the child shows any sort of breathing problems, so at any stage, it requires evaluation to know whether it is due to any infection, whether it is due to the respiratory muscle weakness, or if the child is having some fractures, sometimes even minor traumas can cause. So it can be diagnosed early when appropriate team. And so early diagnosis is crucial in the management. They might require oxygen supplements, avoiding any low BP. So more than the early diagnosis and management, steps to prevent like trauma or preventing trauma may be very important. So regarding dysphagia was another question. To be frank, in our experience, dysphagia reporting is also very less. So, but it is said to be one of the manifestations which is seen in Duchenne muscular dystrophy, especially as the disease advances. They might have more problems with chewing, more problems with swallowing. So children may complain that they have difficulty in swallowing, the food is getting stuck in the throat, they are coughing when they are swallowing, feeling of choking, weight loss, infections, etc. So this again requires assessment by a swallowing specialist. So in our neuromuscular clinic, we also have swallowing specialists who do these kind of tests, which are known as video fluoroscopic swallow studies, fees, etc. And again, this is the general management which is recommended. I'm not going into that. So generally, the 6 monthly, your doubt may be when you have to consult. So if the child is having a problem of is having any complaint of dysphagia, you can consult, or especially when they are in their later stages, especially the non-ambulatory stages, you can have a 6-month visit and assess in your regular follow-ups. The neurologist and the swallowing specialist can assess for any signs of dysphagia. And the feeling can be again due to multiple reasons. It can be gastroesophageal reflex. It can be due to abnormalities with secretions, coughing problems, etc. And so there are different interventions for each stage. So non-invasive ventilations, peg feeding, high-calorie diet, all these are various things which are recommended. So this is a brief overview which I have given regarding the Duchenne muscular dystrophy and also regarding the questions which you have asked. So further questions I think can be taken later. Now over to you. Thank you.
Thank you, Dr. SEENA.
I will continue from where SEENA stopped. SEENA, can you stop sharing the screen? So what I just want to do is to quickly go through whatever other areas that has been raised. raised from 1 minute. I'll just...
But can I ask all the other participants to please mute? Thank you. Yes, doctor, we are clear.
Yes, yes. Right. So SEENA spoke about most of the challenges that has been raised with regard to the pharmacological management and also the symptomatic management. But then as a continuation to that, I just want to highlight that all of us will agree that the medical care has to be parallelly. So the challenges are also psychological and social in nature. Everyday challenges that we face in managing steroids or managing each of those decisions that we take for vaccination or swallowing management or even bone health management, each of those are parallelly going with everyday activities of psychological and social challenges that we are all facing. So as SEENA said, essentially, the literature talks so much about the importance of multidisciplinary care. As parents, we know that the child's neurological management begins by the accurate diagnosis at the early stages. We would be struggling with a lot of challenges that the child has been going through. And then we get the diagnosis. And once the diagnosis is received, then begins the journey of managing everyday process, everyday activities, managing everyday challenges, so to speak, and it can be always multifactorial. So the standards of care in DMD management has to do with accurate diagnosis and also rehabilitation support as transitions happen. As we all know, early stages, the challenges are different, and as problems start becoming more evident, there are different challenges that will happen. So it does involve multidisciplinary care, as SEENA mentioned, and each of the sometimes it is need based, as in if there is a respiratory problem or if there is a fracture or recurrent fracture, accordingly the interventions need to be or consultations need to be managed. But otherwise, routinely there has to be a periodic follow-up for the neurological management and steroid management, and in what way we kind of support the child's activities. These are all essentially multidisciplinary problems, and we really the emphasis from psychological and social dimensions also should be on prevention and early intervention rather than waiting for a lot more problems to happen. Again, some of the questions have been about how much of neuropsychiatric problems are seen. So it is a little difficult on a day-to-day basis to differentiate between how much of the challenges that the child is showing in behavior are part of the disease itself, how much of it or the what we call as a neurocognitive changes, or how much of it of the changes in behavior are part of the child's reaction to being developing the motor problem. So it's a little difficult on an everyday parlance to differentiate these two, but studies do talk about more cognitive impairment. So for example, specific areas of risk in terms of psychological or neuropsychiatric, which is one of the questions that has been raised. There has been a little bit of high risk, increased risk has been reported for neurobehavioral or behavioral changes, basically behavioral concerns, including autism spectrum, ADHD, and sometimes OCD. But then there are also problems of impaired intelligence that has been assessed using neuropsychological battery. And they say that there is one standard deviation lower score in the IQ test that the children have been given according to the studies. And specific learning disabilities, as in learning disorders, are also quite high in the reported studies that have been looked at. This challenges are more for verbal language. So the children whatever studies that have looked at the intellectual impairment, there are more challenges in language development, comprehension, and short-term memory as compared to non-verbal. So non-verbal picture processing kind of activities, the children are better performing compared to verbal. So there could be delayed speech development, there could be language development challenges later on also. So these are some of the current studies, literature that talks about from neuropsychiatric. There are, one question was about whether children with DMD are more susceptible to psychosis. So in a neuropsychiatric profile itself, there is severe mental problems that we talk about as schizophrenia, psychosis, etc., which are not so much reported in our experience also has not been so much that we don't see children with severe mental health problems coming with DMD. What we do see is about a little more depression, anxiety. And again, as I said, it is difficult whether to differentiate whether the depression or the mood changes are secondary to the difficulty with social interactions due to the mobility challenges. So it is, in some cases, the children withdraw so much. Very often we find it difficult to connect with the children. I'm sure many of the parents in this group also will agree. In early stages, the children tend to have more activity, so there could be more ADHD and more attention deficit kind of profile. But over a period of time, children become a little more withdrawn. Emotional adjustment challenges are there. So very often the irritability and behavioral concerns that we see need not be a clinical diagnosed, behavior problems. It is more subclinic in the sense that there is a reaction to what the child is going through in terms of the child is not able to catch up with his friends. When there is equally his own age group, children are doing a lot of things the child finds that he cannot do. So it also has a lot more emotional changes for the child. So along with the challenges that the parents are going through, the child, focusing on the child is very, very important, something that we advocate a lot, because very often the healthcare interactions happen with the parents. Wherever we go with the child, the healthcare interactions with a neurologist or physiotherapist or any of the supportive treatments, the parents are given a lot of information. Parents are told what to do. The child, even though the child could be 13 years, 14 years, even at that stage, the child will not really be directly spoken to. So it is important that we do pay a little bit of attention to the child as a child. And that communication is something that one of the questions has also been, how do we speak to the child about the muscular dystrophy, and at what age? So there are, it is very limited literature has explored at what age we should speak to the child about the disease. In our experience, we have found that there are families who never speak to the child at any point about what kind of challenges the child is going through. Whereas we always, one of the primary suggestions that we give when we see our children, when we see children in our clinic, is to tell the parents that the child has the right to know, because the child will be keeping a lot of concerns in his mind, and it comes out as depression, anxiety, and irritability. Very common challenge that the parents faces, the child does not agree to do exercises. We suggest physiotherapy, we suggest a lot of things. The child does not agree. He becomes very irritable when suggested to do physiotherapy and things like that. Unless and until we explain to the child why we need to do, why physiotherapy is important and why mobility is important, along with steroids and along with the changes that are whatever pharmacological support we provide, the activities, that profile that the child maintains is very important. But the child is also a person. The child needs to be told that why he has to do all these things. That will definitely bring down his anxiety with regard to what is happening to him. Also, all the parents in this group will agree that you would have had a lot of medical consultations to reach the diagnosis itself. reaching the diagnosis is one dimension. And each of those interactions, the child is also listening to. So we really have to speak to the child at some point, giving the accurate information. And what age do we talk to the child is one question that has come. So it has been our experience that very small children also can process a lot of things. So at whatever age that we get the diagnosis, it is important that we parallelly speak to the children also. So the needs of each child will vary, and there are some crucial times that we can really seek neuropsychological or the psychiatric social work in our setting. It depends on the setting where you go for consultation. Who is the multidisciplinary team available where you go for consultation is very important. But it is mandatory that there is a psychological support available for both parents and the child. So because we want a cure. So parents are always concerned about the medical cure that a child will have. But then every day is also important. Everyday challenges that we face that requires a lot of psychological and social support for the child and the parent. So a multidisciplinary team which will support for this is very important. So for the child, one of the questions has been whether to approach a psychiatrist or clinical psychologist, and when do we approach. So the standards of care for DMD, they advise that psychological assessment has to be done near diagnosis, like at early stages of the disease. And then whenever there are changes in functioning, as in the child losing ambulation, that brings in a new set of challenges. That time also we need to have. So one group of assessments are to do with neuropsychological functioning, neurocognitive, as in intelligence, memory, speech and language, and behavior, as in ADHD, attention deficit, or autism spectrum profile. Another group is to do with the emotional challenges that the child will be going through. So assessments has to happen across each of these areas, and a necessary routine screening for these areas is something that is very much advocated. It has to happen to support both the parents and the family as well as the child through each of these processes that are happening. So the interventions are also very much what can we do to support the children and parents are also parallel to the assessment that we spoke about. If there are learning problems, they suggest some of the recommendations are to have an individualized learning educational, because school is a very important space that children grow up in, right? So when physical mobility is limiting accessibility to school, we need to find how do we, so school is not just about learning ABCD. School is also about social interactions that happen there, peer group influences that happen there. So to what extent are we able to normalize the child's schooling, and to what extent we are able to support the child through this, the challenges that, because the small children are also not very sensitive to the differences in the child. So there could be a lot of bullying that the children will face in school also. So that also is something that we need to be sensitive about. But the advantages of going to school and having social interaction is also very valuable. We have had a lot of children who come to us who have very successfully completed schooling and college and doing really well. So at that stage, with a lot of physical challenges, they have been able to complete schooling, and that has actually really helped him to manage the challenges associated with DMD. That is something I want to kind of highlight. So these are about the neuropsychological problems. So again, as I said, social interaction has to be encouraged. So in our setting, we also belong to very different social communities or spheres. So whatever is available in our, so whatever the suggestions that are given in the maybe a Western culture may not really be so much applicable in our context. So we need to find what works in our environment. So children with whatever limited challenges, whatever challenges in mobility and physical problems also, they need to be encouraged in age-appropriate activities while protecting for, falls should not happen, and they should not really land up in more difficulties. That kind of protection should be there, but at the same time, within that sphere, normal age-appropriate activities, how we can provide for the child is very, very important, promoting the child's independence. So as parents, we would like to protect the child from having, the negative experiences. But, those experiences are also important for child to be a little more, to have a life. So this is a balancing act. It is easy to say a lot of things, but then to do is more difficult. But we need to really find in our environment what are some of the social interactions that the child can have. Whenever there is withdrawal, we find a lot more withdrawal in the children. So to what extent we can have experiences that the child can interact a little more. These are all things that will ultimately bring down the psychological challenges. So lot of questions have been about how do we manage behavior problems? How do we manage neuropsychological problems? But as I said in the beginning, a part of it is part of the disease, but a part of it is also because of reduced interaction and also the child's own emotional challenges of going through limited physical problems, so limited mobility. So we need to give a lot more experiences that will help the child to have more interaction. That will also bring down irritability, behavior problems in turn. Educational interventions, as I said, we really have to find activities that will modify potentially harmful activities. For example, physical education and a lot of running and long distance things, the child will not be able to do. Even in early stages, when the child is ambulant, there will be a lot more tiredness and difficulty in doing things. Fatigue will be there. So from early on, as I said, the focus is very much on prevention and early intervention. From early on stages itself, we need to find activities wherein the child can engage in, but preventing for problems and with adequate safety mechanisms. We should have more and more. So we should try to find a balance between these two things is the point that I wanted to make. So one final question has been about families. How do we manage? So it is, there is no one way of family. How do families manage? How do we cope? It is highly individual based. Each family manages the DMD. I'm sure if there are 50 families in this group, each family has unique challenges, and you find your own ways of coping with DMD, the diagnosis of DMD. One question has been about palliative care. A lot of parents consider the word palliative to be very difficult to process because it is something that is very distressing. But by palliative, it just means supportive care. There is nothing about nothing that indicates any kind of that by word itself does not mean anything distressing. It's about supportive care. We need to ensure support is there for the child. For it could be so a lot of interventions which SEENA mentioned for bone density management and fracture management and sleep and pulmonary support, the support for respiratory respiration, all these things over a period of time, as and when needs happen, we need to support the child through this. Even the emotional support that we spoke about, as well as all other areas for support, all these come under the supportive care that the child will require. And in supportive care or in palliative care, we also talk about the support the family requires. The parents equally require support as transition happen. There was one question about hospice. We in India, we do not really have hospices that cater to the very unique needs that the children are going through. But we, home care, home-based supportive care is what we have found to be very useful, and what our families are doing. So finding the right team to support children at home, and it is essentially multidisciplinary. As problems happen, how do we kind of support the child through this process, and how do families receive the support. That is what supportive care is all about. The communication with the extended family is another question. What do we tell other people? What do we tell? So the communication about DMD, first and foremost, I'm a major advocate of telling the child in his own language what he can understand, what he is going through is very important, as I said in the beginning also. That is something our team has found. One of the research that we have done in our own setting has also been the child want to be listened to. Child may not come out and say because he is afraid of distressing the parents more. They don't, because they see how much distressed the parents are. So they don't ask more questions. So in one of the research work, PhD work that we have done, we have found that the children want to be listened to. They want somebody to talk to them. They have a lot of questions they want answers for, but then they don't know whom to ask because they are afraid of distressing the parents more. So we need to also take care of that. That is about communication with the child. We also should tell other people, as in extended family is a question that 2-3 questions, but then, again, as I said, it varies from one family to another. But then there are extended family, neighborhood, all these are so the disease is there, but it is the child who is more important. It is not the parents' distress that is more important. It is a child's experience. The child's distress has to be equally taken care of, because parents can speak, right? Parents are adults. So they will ask the child, unless and until given a platform, the child, unless specifically asked for, child will not speak. So rather than diagnosing neuropsychological problems and behavior problems and things like that, yes, there are reports of autism spectrum ADHD, but most of the changes that are seen in psychological functioning in the children are subclinical. Subclinical in the sense that it is not diagnosable. It's more minor changes that everyday activities we see, a little more withdrawal, a little more problems in social interaction. All those things can be there. So that needs to be addressed on a one-to-one basis by the multidisciplinary care. We should remember that just as they are going through the challenges, the child is also interacting with parents, his friends in the school, neighborhood, the society around him, whatever people are there. The hospital that we take the child to, the child is interacting there also. So all these, the teachers that the child is interacting with, each of these people have an influence on how the child is. So, and if we pay attention to that, it will help us to manage how the child's irritability, behavior problems, all those things, that those questions about the child's irritability, behavior problems, most of those things can be managed by paying attention to and talking to the child and providing emotional support. And I think it is, it's better if we take some more questions from here.
Okay.
Over to
Hi,
you. Yeah.
So there are a few questions that have come in, and I'll just go one by one. I don't know who will pick up the questions, but yes. Okay. So the first one says, how much does DMD affect brain function?
Yeah,
See,
SEENA,
how much it
what do you think?
affects-
Yeah,
Yeah.
SEENA, go ahead.
So how much it affects, as I told, it varies depending upon the genetic mutation. So the DMD gene is one of the largest genes. It has so-called 79 exon. You can just take it that it has 79 part. The different types of proteins also, as I showed you. So with each genetic defect, the protein which is produced or the isoform which is affected varies. Okay. So we cannot universally tell every child is going to have a problem. As ma'am mentioned, we have had children who were very bright, who have completed their schooling, colleging in good way. And we have had actually doctors who have of Duchenne muscular dystrophy. So we have had very bright children. Okay. So, but there are some who have problems also in their scholastic performance, some with attention deficit, some with autism. So it all depends upon we tell genotype phenotype correlation. So which genes, which part of the gene is affected, which isoform is affected. So even with the same gene mutations, it can vary. So the studies and more functional studies on how each one is affected. So the research and science is throwing more and more light on that. Okay. So we needn't fear that every child is having problem. Okay. Some do have. And if the child has any problems like hyperactivity, some difficulties in their studies, reading disabilities, so please seek appropriate attention.
So there's another question, I think, Dr. Priya. Why do DMD boys talk too much and they're adamant on everything?
Yeah, I think that is what I've been talking so much about. It's not about. I mean, it is not fair to them to label. We should realize that the children are actually going through so much of challenges in their age, which another child in their own age, if we see it from that perspective, another child will be going through so much of activity, so much of things. Our child is not able to do that. So to some extent, children also, as I said, through comes out as adamant. So as I said when I was talking also, very often one of the challenges parents face is the children do not do exercises. Don't do exercise. They are adamant when parents are telling them to do exercises. So and that I would say it is also because we need to communicate with the child that why they need to do exercises or wherever. The adamance, it is also always contextual, right? When we say child is adamant, when we ask them to do something and they don't do. So parents are adults, so we need to be able to process it a little better than what a child at that time, maybe 5-year, 6-year-old children, how much will they be able to process? In their language, we need to be able to tell them why something is required or when something cannot be done. And definitely, if we talk to the child, the adamancy will come down. But as we have been telling, there is also a little bit of grasping problems and attention problems that the children do have. Children will not sit in one place. They talk a lot. All those things are there. Part of this attention deficit spectrum could be there. It may not be a diagnosable thing. Those studies are actually talking about high percentage of ADHD in the children with DMD. But then in our experience, it has been also that it is subclinical. Children will not sit in one place and they will not stop talking. All these things are there. Let us actually let the children speak. If there is no I mean, the children will grow up, right? Let them speak when they want to speak. Let us not see it as something pathological, as a problem thing. So, but speak to the child about why something has to be done or not. That will bring down the adamance. That's what I wanted to say.
Yeah. Okay. Thank you. Thank you. So there is always more pain in the knees and the foot. So this is one recurring problem all moms face. So evenings, they're maybe tired and then the pain starts. So what do we do to address this pain?
So one thing is why that pain is, we can tackle in different ways. So one is, first of all, as I mentioned, whether it is related to any osteoporosis or other things which they have. Is their vitamin D levels, calcium supplement, everything adequate? We can check all those aspects. The other thing is, as such, they can have muscle pains. And of course, some of the muscles are weak. So there is an overuse of some muscles. So there is a strain. So they can feel backache and other things. So as I mentioned, some of these disciplinary things, like we used to even have our integrative medicine, Ayurveda, some oil massaging. You can just use it at home. Some of the oil massages, no, you don't have to be under regular care or something, admissions and things like that, but sort of oil massages and things also help them. So it needn't be on a daily basis also. So that also will help in relieving some of these muscle pains. But most important may be to make sure why they are having, and also the regular physiotherapy. Okay, regular stretching, mild physiotherapy. So physiotherapy as well as the cause of the pain. Is it due to any other bone related or other things? So assessing these two may be very important. And then of course, some oil massaging and things might also help.
We have always been told that massaging these muscles are not good for our
It's not
kids.
a too much forceful massage, just a
Okay.
sort of applying and a mild this thing. That's
Okay. Okay. I mean, I just want to clarify because then that'll be the
Mm.
next question in the next seminar or webinar. Okay. Thank you. Now, how do we prevent this scoliosis and spinal issues that we face with the kids?
See, the main care one is steroids also help in preventing the scoliosis. And the second thing is there are exercises where the physiotherapist can advise specifically the exercises for the back muscles also. So these are two aspects which will help. So breathing exercises, back exercises, as well as the use of steroids will help. So to add on to the previous one, the parents who are listening here, they needn't think, okay, the other oil massage things will help. They should not take them to centers which don't have any expertise or other things. What I meant is just applying it at home, because there are various centers or hospitals which might advertise for various things, contracture release, they will be tying up the child's leg and then making them forcibly stand, and some of them going on to vigorous massages like you told. So all these kind of things which are happening from inexperienced people and not who are authenticated to do so can lead the child to more problems. So what I meant is just what you can do, the mild one at home. Okay.
Can I just add to say that if some centers say that you give so much of money and then we will correct, there will be a very rigorous regime and then we will correct this and cure this and all those things. Please don't go to such centers and spend so much of money. We find a lot of distress spending. People spend lakhs and lakhs of rupees because in these centers, as we said, there won't be any scientific method followed. They just give a lot of hope, but then put the children through a lot of rigorous unscientific methods. So you need to really be a little cautious about that. It's not just about, so whatever supportive measures that we can take, Ayurveda or massage and all those things, do it with the trained people and follow whatever instructions are given in the at home. That is the best possible option.
Rajisha, you want to ask something?
Yes. Actually, I just want to ask, like I met Dr. Ann last week. So, my son is having a foot drop kind of thing. Like toe walking was there, but now it has been reduced, and we are using that support also. So, and this for the foot drop thing, suggested like casting, do a casting for 1 week. And so how about that? Like we went to different doctors, and we are currently taking from NIMHANS also. So in other like opinions, I got it, and I went and checked with that doctor also. So this has been suggested. So I just want to know, like this is good, or like for 1 week, and after that we can remove that casting. So that was my like doubt. Like I don't know. Like
See, like
so.
I
Mm,
mentioned for,
mm,
so these cannot be in a universal manner for all the children. Okay, so contractures, as I mentioned, is very common in these children. So he is having some ankle contracture. So the ankle contracture is what is making him walk on his toes. Okay. So again, it depends upon how severe is the contracture. So of course, casting is also advised for a few days and then releasing it and some stretching exercises. It all depends upon how severe it is. I think our physiotherapist will be able to see the child and assess and tell you what all should be done. See, if there are ankle foot orthosis, various things are recommended, but it is all not like universal. So in some of the stages, it may actually not be recommended. Ankle foot orthosis may not help. So it depends upon varying, it is different for each child. Okay. So a physiotherapist can see and assess and tell you. Okay.
Okay. Thank you.
Rajisha, you can mute yourself. Thank you. So what about, see, we have a lot of kids who are on the older, my child himself is 21. We have elder kids also here. So what about these antidepressants and anti-xylol, the other drugs? How do they work with our kids? So if we give them with steroids, how do they help? How do they not help? Proper overview of this.
Antidepressants and antipsychotics are need-based, right? If the child has diagnosed depression, which is interfering with his daily activities, with proper guidance from the psychiatrist, and sometimes the children have diagnosable anger issues, diagnosable problems with psychosis and things like that, very rarely. But then a proper consultation with the psychiatrist is very important. And the steroids does not in itself lead to behavior problems. As in, the studies do not find that in DMD children as a side effect. But then, other things, taken everything into consideration, appropriate consultation, and taking the whole picture of what are the problems and what is the current medication, and then considering which antidepressant and how long and all those things. That sequence of events is probably very important for this. SEENA, you want to add anything?
So I will also agree with madam. You can therefore, if it is really indicated, so we can give the antidepressants along with the steroids. So steroids, as such, like ma'am told, we don't find any problems in our children, and steroid should be continued. Okay. So as I mentioned, even after they lose ambulation, it should be continued for the cardioprotective effects and upper limb functions. We can add on the antidepressants along with the steroids.
Sharda ji, you want to ask something?
Yes, unmute. Sorry, I just had a couple of questions, ma'am. One is, do we have pharmacogenetic testing available in India? And if yes, how effective are they? Pharmacogenetic testing.
I'm not aware of pharmacogenetic testing being done in India. Maybe I don't know whether on a research basis people are doing, but otherwise, as such, I'm not aware.
Okay. And also, does anesthesia during long surgeries, do they trigger any imbalance in the neurotransmitters in the brain?
See, I don't think there are studies on whether changes in the neurotransmitter as such happen. See, basically, when we are worried in surgeries in these children, it's more because of their respiratory and cardiac status. So what anesthesia to use because of problems like hyperkalemias and malignant hyperthermias, or other problems like respiratory muscle weakness. So whether they have problems in coming out of that. So those are the main concern. The neurotransmitter per se, I don't think the anesthetic agent is going to cause any changes like that. So of course, as I mentioned, so the Duchenne children, they should have a proper cardiac respiratory assessment before they undergo any surgery. And also the choice of the anesthetic agent has to be very careful.
Thank you. Thank you.
I'll just finish these questions, then I'll take questions from Sneha ji. So we have kids who are 8, 9 and having problems to read and write. So how do parents enable them to overcome such problems?
As I said, early assessment is very important. When we recognize that the children are finding it difficult to catch up with age-appropriate scholastic activities, it is important to have a neuropsychological assessment to identify whether there is a specific learning problem that the child is having, and accordingly there has to be an individualized educational support. In general, also specific learning disability requires individualized learning programs for the children. So it doesn't, that is in the general population. Same thing is applicable in DMD also. If the child is having learning problem identified, it has to be properly assessed as from child psychiatry or neuropsychology. As in, child psychologists can really help in categorizing this and developing tailor-made programs for supporting education. Unique education needs will be there, which can be identified and supported. That is about learning and reading problems.
Thank you. Now we have older kids who are not on steroids. So if they want to get on steroids, how do they start? Weekend dosing or high doses? How do they work with it?
So we have generally been following a protocol of daily dosages. So like I mentioned, in the children who are in the higher age group also, if they are ambulatory, we can start at the dosage which I mentioned itself, 0.75 mg per kg of prednisolone. So if they are not ambulant, then we reduce the dosage, but we keep it at a minimum low level, like at least 20 mg or something, so that they can have. So 0.5, 0.3 to 0.5 mg per kg of steroids can be kept so that their hand functions, their cardiac functions are maintained. So we don't go ahead with the intermittent regimen or with the weekend regimens. We have not been following. But generally, if you see the studies also, they say the side effect or other things with the weekend regimens or the high dose regimens are also almost the same. So in our experience, we have been following a universal practice of continuing the daily regimen. So with the children who are in the higher age group also, as I mentioned, it is very important to be aware of their cardiac status and things. So when we do an echo as such, it may be normal, but if you do a cardiac MRI, they might have some early changes. So the use of steroids and appropriate cardioprotective medicines, like I mentioned, it is our protocol to start Ramipril for every child who is about 10 years of age. So with the use of the steroids and the cardioprotective medicines, now at 17, 18, 19 or 20 years also, we are not finding much cardiac changes on echo. Okay, so maybe the MRI wise, we are able to pick up. So that is something which is very important. Children in the higher age group, they have to have more frequent assessments, regular medicines. So there are multiple things which they have to be taken care of.
Daminiji, you want to ask something?
Yeah, ma'am. Ma'am, my son is 9 years old. He's losing his back posture, ma'am.
Okay, so as I mentioned, I think you should meet a physiotherapist who can correctly assess what are the problems. So the back muscle exercises along with the usage of medications will be important.
Ma'am, as
There are
the
correct posture, maintaining the correct posture and back strengthening exercises. This will be important.
is there any type of belt we can use, ma'am?
See, as such, we don't routinely recommend, and those actually might be causing more problems for the child. So I think on an individual basis, it has to be assessed by the physiotherapist and then it needs to be taken care of. I think the usage of belt as such may not be advisable for every child.
Thank you, ma'am. Ma'am, one more question. I am a mother of DMD and I am a carrier. Recently, I'm facing more pains in my left hand muscles. Is this sign because of I am a carrier and I'm do I face any type of muscles pain in future?
See, the hand pain, usually the muscle pains which are experienced can be more in the thigh muscles, calf muscles, etc. So the hand pain may or may not be related. So there are various causes again for the hand pain. So people like, for example, with carpal tunnel also have pain. So whether you are having any hypothyroidism, any other problem. So what is the cause of the hand muscle pain? Is it due to any other cause? Will have to be assessed. So if you feel other muscle pains, you can just see how much is your CK levels. And I don't think if the muscle pain is troublesome, only then you need to bother about it. I think the hand pain, one hand pain alone may not be a marker that it is a myalgia due to your career status. I feel it might be related to the other reasons. Okay, so which you can just check. Okay.
Thank you, Daminiji. I'll take a question from Taramaniji now. Murliji?
Yeah, ma'am. This is not related to the any specific to the disease or other thing. It's related to a administrative thing. Like as you people know that we kids are more vulnerable to the infections and other things. It's most of the people are saying that if you visit NIMHANS, it's taking a long time to get the consultation and other things. I don't know how you people can give that window, as we stay at Hyderabad, and then we are very closely with the NIMS and then other doctors. They are given a time from 1:30 to 3 o'clock, where we will specifically take time, and then we will consult the doctor, so that it will help our kids. I don't know how you people can help that, because my founder directors and then active members are at Bangalore. How you can help that? That is my request, ma'am.
So you can come anytime to us. So I think there is a misconception also that getting to see a doctor in NIMHANS is very difficult. See, as a Professor Nalini, our neuromuscular specialist, one of the most important experts in the country, she has her OPD on Monday. I am also part of her team. We are all there on Mondays. So you can take an online registration. So NIMHANS has a website. Please go to the website. You can take an online registration. But if the online registration is difficult, don't worry. You can come over directly. You can take an online. You can take a registration at the counter. And any Monday, just walk to us. Walk to our OPD. We don't restrict any number of cases. You can definitely meet one of us. Okay. So don't worry.
Yeah, I can I just add.
Thank you, ma'am.
We generally we prioritize children and also people who have more difficulty, because it is true that NIMHANS has a lot of patients. It is also because we are trying to provide the same standard of care to everybody who reaches out to us, without having appointment system and things like that. But what we are trying to do specifically for a neuromuscular and also for example, elderly are also to make sure that we first itself, Dr. Nalini makes it a point to filter in the beginning itself, make sure that children with muscle problems and people who have more difficulties are seen earlier. So we do have a fast tracking kind of process there. But I must agree that it will take time, because it is because of the process involved is very detailed. And we do spend a lot of time with our children as in trying to make the correct. And also one of the challenges is that, as all of you will agree, that a lot of people come from different parts of the country. So they would have gone through a lot of previous healthcare experiences. So it takes time to decipher that. These are some of the reasons for the delays. But then, as we said, we do try to prioritize children. So please come if you need help. And we also have this multidisciplinary care very much well in place in NIMHANS. And please, you are always welcome to come. Reach us on Monday.
Thank
Taramani
you.
ji, will take your question now?
Yes, ma'am. Ma'am, actually, the new medicine norms I already wrote in the chart. The new medicines which are that can help our children for the DMD.
Regarding the new medicines, ma'am, I think you might be meaning about the exon skippings and various forms of gene therapies. See, basically, those therapies are not freely available. So those are basically exon skipping and things. They're trying basically to reduce the severity of dystrophinopathy, to make the Duchenne to a milder Becker phenotype. So basically, as I mentioned, out of the 79 parts, the most of the children have problems in the 45 to 55. So that is so-called hotspot. So they are trying to overcome. So basically the protein, dystrophin production stops in an affected site. So basically with these gene therapies, they're trying to maintain some protein production so that they have a milder form. That is what is done by the so-called exon skipping, which skips one exon, one part, and the reading frame or the DNA is read fully, the protein production continues. So it is available for only few exons, say like exon 45, exon 51, exon 53, etc. And even for those, it is not like freely available in India on a research basis, on a trial basis. It is tried in few centers. So they are all very costly, expensive, and not available for all the exons and not freely available. So we in NIMHANS, we had previously drug trial for the mutation. The Ataluren PTC drug trial was there, which is now over. So there are some centers in Mumbai, Chennai, etc., which may be having drug trials for particular exons. Otherwise, as such, the drugs, the standard of care basically is what I have mentioned, the steroids and others. So let us see what are the new things come up in the future.
Ma'am, my son also.
I'll
Can I
take
ask
only
one
one
more
question, Taraji, because I think I'm holding them for a very long time. I'll
Okay,
take
ma'am,
Sneha
okay.
ji's question now, and that'll be the last question I'll be taking. Thank you.
Hello.
Ha, Sneha ji.
Yeah. Thank you so much, Dr. Priya and Dr.SEENA. It was a very informative and educative talk. And I'm proud to say that my son, Dr. Sarthak Kamath, was in Dr. SEENA's and Nalini's unit during his MD posting. Yeah, he's
Thank you.
We are so
Thank
proud
you
of
for,
you.
yes, thank you for bringing that component. This is what we have been trying to tell everybody, that a lot of, we want to give this message that it is possible. Dr. Sarthak has been part of our team. It is very nice to see him reaching that level. And it is your support, Madam Sneha, that has made it
Thank you so much.
Yeah.
No, I want to give a message that, like you said, nothing, where there's a will, there's a way. So people need not give up. You can become doctors also with DMD problems.
That's
Yeah.
exactly what we have been telling to our children, ma'am. We have had, when I told about the doctor here, I meant Dr. Sarthak. So
I
we have
understood.
So there are doctors, there are people in different professions. Our children have come up so well. Sometimes I'm amazed by their skills. Some of them sing so well, some of them do paint so well. So recently I had a 22-year-old who continuously does some diya decoration, so many things, and he had an amazing memory. And if you tell any date, he's from between, I think, 2000 to till now, he's able to tell you which day of the week it was in a fraction of a second. So those are the amazing skills of our children. So we are proud of them. So you don't have to, that's why I told, don't have to worry that cognition is going to be affected in everybody. No, it's not going to be affected in all. They have their unique abilities, unique talents. We just have to recognize that, keep fostering them, nourishing them, don't restrict them in anything. Priya Madam and her team are doing a wonderful job, trying therefore to encourage children to go forward in everything, in their schooling and in all aspects. So that's our message to you all. So not to worry too much. Keep following the standard care and bring up your children.
And please convey our regards to Dr. Nalini.
Sure, ma'am.
Thank you so much.
Thank you, Dr. Priya, Dr. SEENA. I think I have pestered you a lot, and you people have been very gracious, and then you've given us so much of your time. And I don't know how to thank Dr. Nalini, because she is the one who actually put me across to you people. And she normally tells me that you attend about 400 patients in a day. Hats off to you, ladies. I don't know how you do it, but then thank you so much for doing so much to our community. And we loved having you here. And I don't know, we'll have you more, and then we'll come up with newer questions, and then we'll try to address more issues with our community. And I think Sharda ji wants to say something in the end. I'll hand it over to Sharda ji.
Thank you, ma'am. Thank you, doctors, for the wonderful and informative session. I just had one general question. This is for the DMD community pan-India. You have a psychiatric social workers psychiatrist department there. So are you doing any workshops or training in other places pan-India, so that these services are available everywhere for all the community people?
You could train us. As in, we don't really do, it depends, like, so it is done case by case. So whenever somebody is asking us for training, we do provide training. We do have workshops for capacity building, you know, how to work with children, how to work with this psychological distress and things like that. But then it depends on the request from people. So if you would like us to do training, we have a team of people. I've had a lot of PhD students who have worked with emotional issues and working with children and working with other emotional distress, things like that. So we will be able to do training sessions and capacity building programs, workshops. We are happy to do that, actually. I feel we should do it. So my concluding comments, as SEENA said, is that though it is a difficult diagnosis and difficult challenge to have happened, it is not the end. There are so many things that can be done, and our children are at the center of it. The children really are marvelous. We just need to, as parents, it is just as we need to find the medical support, it is equally important to speak to the child. That continues to be my message. I will keep on saying that we really have to speak to the child and support the child through his development. Definitely, they will be able to do beautiful, a lot of marvelous things they will be able to do. So please take that hopeful message, and we hope that it has been useful to you. Any kind of training programs, please reach out to us. I will be happy to. It is a team always, so we will be happy to do this. Thank you very much.
So much. Thank you so much, Doctor.
Thank you.
Yeah,
Thank you
thank
all
you
for
so
giving
much.
us the opportunity.
Yeah, thank you so much, Dr. Priya and Dr. SEENA. Thank you, Ashwini, for making this happen. Very, very informative and lovely session. We would like to see both of the doctors every month, if it is possible.
Sure, ma'am. We are open to more interactions. We also loved interacting with you. So we are happy to help you in any way. Anyone of you, like Mr. Murali sir asked, anyone of you are open to come to us also. So we are really there for the kids and for you.
Yeah, he is one of the founder of Bharat MD Foundation.
Okay.
Thanks a ton for everyone joining at this hour.
Thank you.
Thank you,
so
ma'am.
much.
Thank you.
Thank you, everybody.
Thank you, everybody. Special thanks to
Bye.
Ashwini and
Thank
SEENA
you,
ma'am
thank you, Ashwini.
and Priya ma'am.